Thanks, Murray. Next, I'm going to talk about critical limb ischemia of the upper extremity. There's a fair bit of overlap here with what Dr. Matos talked about, but I guess the focus here is not just on, not necessarily on things like claudication and TOS, but critical ischemia of the hand and upper extremity. The epidemiology of this problem, it's very rare, a lot less rare than the lower extremity, and that's because the upper extremity really has a excellent collateral supply that can continue feeding the hand despite blockages of the large vessel. And as Dr. Matos indicated, the list of potential pathologic causes is really, well, he counted this list actually. I guess I didn't go to the trouble of counting it, but 38 pathologies, 75 different causes I think he came up with, and that's, it just makes the point that you have to have a very broad differential here. I think when you're in clinical practice, really, most of what you see when you see patients with gangrene, rest pain, or ulcers on the fingers, the great majority is actually going to be Steele syndrome related to dialysis access. If you're seeing this in the emergency room setting, it's often going to be a drug-induced problem. And then a certain percentage will be thromboembolism, and then a remaining category will be Raynaud's disease and Raynaud's phenomenon. Who can tell me the difference? Anybody? Intern from UCLA, Dr. Rigberg? Yeah. So as you know, Raynaud's phenomenon is the clinical syndrome and implies that it is the secondary, it's due to a known underlying disorder, lupus, scleroderma. Raynaud's disease means that it's idiopathic. You don't know. So that's there's no other known explanation for it. Also now, most of the textbooks have moved to calling this primary and secondary Raynaud's rather than the old terms of Raynaud's disease and Raynaud's phenomenon. So those are the four major categories when you see people with tissue loss and ulcers in your office of the hand. Less commonly, you're going to see all these sort of autoimmune things, although you will see Berger's disease, and we'll talk a little bit about that. As Dr. Matos alluded to, the history and examination are really crucial factors. I mean, you can learn a lot from a detailed and careful pulse examination and an examination of actually what the pattern and of the ulceration and the pattern of the tissue loss is. He's already shown better color pictures of Raynaud's. So how do you work this up? You're in the office and sort of you have to have an algorithmic approach, and I think really that it comes down to sort of two types of things. You need some physiologic studies, and then you need some anatomic kind of road mapping studies. And the physiologic studies that would supplement your physical exam are bilateral arm pressures, segmental pressures at different levels of the arm, and then getting digital pulse volume recordings comparing the affected side to the unaffected side. This then can be followed with sort of, with anatomic, more anatomic investigation, first via duplex ultrasound, then via either CT or MR angiography, or potentially selective, subtraction angiography. So I think that maybe this shows the collateral supply of the arm, and I think what I've been very impressed with is that what many people don't realize is that the deep brachial artery can be a very big artery. So you will see patients who have a total occlusion, both acute and chronic, of their brachial artery, and via the collaterals from the deep brachial artery through those radial and ulnar collateral arteries will actually still have pretty reasonable flow into the forearm and the hand. So you have to really do a careful examination. The arm is very well collateralized, and to some degree, unless the blockage is very distal, can really tolerate a pretty severe degree of occlusion of the vessels. It's important then to understand also the deep palmar arch. Obviously, this is the basis for the Allen's test, to evaluate the continuity of the arch between the radial and ulnar arteries. So let's talk about maybe the most common thing you'll see in practice when you have ulceration of the fingertips, and that's when you have steel. Now, really, you can make this diagnosis to some extent just on your physical exam. So if you have someone who's had long-standing dialysis access, often it's been an access that has been very functional, a very good access. It'll be something that'll never have given them problems at dialysis. You'll see patients with flow rates of 3, 4, 5,000 who then at some point might develop ulceration of the fingertips. And if they have pulselessness at the wrist, if you just compress their fistula with your hand and then examine their wrist with compression of the fistula or the graft, well, then you'll get return of pulses. And this is that, really you can diagnose this problem just on physical exam. But then it's nice to actually, quantitate this a little bit and prove it in the laboratory with digital plethysmography, and easy for me to say. And then you have flat line, no flow with the access open, and then with compression of the graft or the fistula, you get return of pulsatile flow in the digits. Duplex ultrasound, what you see here is, so if you look here, and this is small, so I'll ask you guys, if you look here, you see antegrade flow in the brachial artery, upper left, and then you see retrograde flow in the brachial artery distal to the anastomosis of the access. So essentially, you see reversal of flow, which is one of the pathognomonic features of Steele syndrome. So now you see retrograde flow in the brachial artery distally, and you see retrograde flow in the forearm, either the radial or the arteries distally. But if you compress the fistula on your duplex ultrasonography, then you see return of antegrade flow. And this is also a diagnostic of the potential for a Steele syndrome. CT angiogram plays a big role as well in the imaging of to look for either occlusive or embologenic sources of hand ischemia. Here you see a high-grade proximal subclavian stenosis, but you see there's some sort of fresh thrombus on top of chronic calcific occlusion. Selective arteriography then is often necessary to necessary to determine what your treatment options are. Not always necessary for diagnosis, but necessary to plan your treatment. And you can see here an arch aortogram and a subsequent selective view, first of the subclavian artery, and then you have to, as Dr. Mattos said, you really have to get your catheter well out into the brachial artery, often use vasodilators in order to really get yourself a good roadmap of the upper extremity arteries, as shown here in the more distal aspects. And then really when you see no occlusive lesions through the course of the arm in the major vessels, then you really want to pay some very close attention towards getting good imaging of the hand. And here you can see the obliteration of the digital vessels in the second and third fingers, as well as no evidence of a complete palmar arch. Often then you can use some provocative maneuvers in order to sort of uncover, to really visualize and uncover the lesions on arteriography, either intraarterial vasodilators or just getting the patients to utilize the hands, open and close their fists in order to induce some reactive hyperemia. Again, here showing some increased flow with and without vasodilators, allowing you to image the digital arteries. So, what are your treatment options if in fact you do have occlusive lesions of the major arteries? Well, the first, for acute arterial embolus, you do have sort of the typical two options, either catheter-directed thrombolysis or surgical thromboembolectomy. And I think in most cases that surgery will probably be the treatment of choice in most cases. There, obviously the risk of lysis in any case, lower extremity or upper extremity, is showering clot distally. Sometimes you can make the ischemia worse, and so I think it's a little more prone to that in an upper extremity situation. So if you have a way to just remove the thrombus surgically or the embolus, and you have reasonable outflow into the forearm, into the hand, usually surgical therapy is going to be the preferred treatment in most cases. If you have occlusive lesions from which either the thrombus originated or it has simply caused a low flow state that's led to the critical limb ischemia, then again you have your sort of percutaneous versus open options, and surgical bypass performed even to the forearm vessels with autogenous vein is an option for severe occlusive disease. As you know, it's typical to the lower extremity. This is a situation when you're sewing to distal brachial artery, often highly calcified forearm vessels. It's even hard to get it technically sewn with prosthetic. You know, you really need autogenous conduit in this kind of situation. So thromboembolism, here's an example of this where you see this sort of thrombus in the subclavian artery just distal to the vertebral artery. You can imagine that that's quite a bit of stroke risk, posterior circulation stroke risk, in addition to a risk to the arm. When you're thinking about embolectomy, almost all of the time, you know, if the embolus or the thrombus is in the brachial artery, no matter often how proximal, I think it often makes sense to start at the brachial artery bifurcation. You know, so you expose that in the antecubital crease, you control your radial and ulnar artery outflow. It's important to make the arteriotomy in the distal brachial artery, but actually you want to have it relatively close to the bifurcation so that you can direct small Fogarty balloons both ways, you know, analogous to a distal popliteal arteriotomy, where you can direct you can direct your balloons down the different tibials. You want to be able to do that into the ulnar and the radial. And you know, embolectomy via brachial approach is surprisingly successful in sort of even in retrieving thrombi or embolus all the way up, you know, even far up into the axillary artery. Patch closure is really only necessary if you've done a longitudinal arteriotomy, which, you know, anticipating the potential for a bypass, which is a relatively rare scenario. Almost all the time, this is going to be a transverse arteriotomy. Subsequent anticoagulation pretty aggressively after you've done the embolectomy. And this is often what you'll retrieve. These tend to be some of the most satisfying procedures, and because they tend to not take very long. You tend to get a lot of clot, tend to be able to close things with about 5, 6 O's or 7 O's, and you know, tend to have very good success for straightforward upper extremity embolism. So what about large vessel reconstruction? If you're occlusive or your thromboembolic lesions are proximal, here's one thing you probably don't want to do. So you see this covered stent extend out right through I mean, this picture shows it briefly, right through the thoracic outlet. I mean, that is a setup for being crushed, you know, crush injury to the stent and recurrent problems. Probably a better scenario for doing a carotid artery to subclavian bypass, or even a common carotid artery to axillary bypass here in the armpit, or even down the brachial, which, you know, tends to be very effective. And if you use a vein graft for these longer bypasses, you know, tends to, you know, surprisingly, despite often a superficial tunnel over the clavicle to get to the axillary or the brachial, a vein graft will tolerate that very well, and that'll have good long-term durability. So what about subclavian and axillary artery aneurysms? Sometimes they can be diagnosed on physical exam. You know, you feel the axilla, the infraclavicular fossa, the supraclavicular fossa. They'll often present with digital ischemia or compressive symptoms along the lines that Dr. Matos talked about with arterial TOS. Again, the non-invasive studies and some sort of axial imaging is going to be necessary to really make the diagnosis. You do get clues on catheter angiography as to the presence of an aneurysm, these little defects, or sort of a somewhat enlarged appearance of the artery, and then you get some signs that there's been, you know, obvious distal embolism from these lesions. This has already been talked about a good bit. You know, what the arterial pathology that you get, and, you know, obviously arterial TOS is rare. But when you do see these aneurysms, you're going to need a broader exposure, really, in most cases, to reconstruct the artery than you need for typical venous TOS or neurogenic TOS. So, because you're going to really have to make sure that you can get proximal distal control around what can be a fairly large aneurysm. So often that takes a combination of either of a supraclavicular approach to get proximal control on the artery with either an infraclavicular approach or really an infraclavicular approach to get distal control, and then decide which kind of reconstruction you need. And here is shown of a very redundant artery with an aneurysm that was just fixed with simple primary repair. And again, here is sort of shown some of the options for repair. I don't think that many people actually would do what you did in B here, which very few people would do sort of a tailoring repair of an aneurysm where, that you might do in other areas where you resect the aneurysm and sort of repair with a patch. Mostly this needs to be resected with careful attention paid to keeping flow, particularly to the vertebral artery. And you'll usually either do a primary repair or some form of interposition graft would be the most common. In very rare instances, you might have an aneurysm where it's proximal to the thoracic outlet and a stent graft would not be crushed. Pretty unusual. There are, or maybe in palliative situations in really high-risk patients who are embolizing from this sort of lesion. Maybe if, an older person who doesn't use their upper extremity much and the risk of crushing the stent might be lower. But in a few instances, it might be amenable to a stent graft repair. So Takayasu's arteritis, we're kind of getting into the inflammatory rheumatologic sort of, causes of, and vasculitic causes of occlusive disease. Takayasu's is sort of a, very rare, but sort of a favorite board question kind of disease. It's of unknown etiology, but it tends to occur in women and it tends to occur in young women. And often known as pulseless disease. So Takayasu's, affects the large vessels to the medium-sized vessels. So it's almost always the great vessels in the aorta, the great vessels, and then the aorta itself. There are 6 anatomic patterns, which I can't claim to remember, but this is associated with an elevated sed rate. And the 6 patterns are here. This is the Tokyo International classification. And most commonly what you see, though, is, in a vascular surgery practice is type 1. So you see great vessel disease and upper extremity disease for the most part. This might be a typical appearance. You see here just 2 cuts, a fairly normal appearing apex of the aortic arch, but then you notice this small sort of inflamed diminutive appearance of the right subclavian, the right subclavian, the right common carotid artery, the left, and the left subclavian. They're all sort of imaged here, kind of a narrowed, tapered lumen with a fair bit of inflammation around the vessels. So in the acute phase, when people, they'll often have a kind of a, an inflammatory syndrome. They'll have headache, fever, malaise, not feeling well. When you're in that phase, that is definitely a phase where you want to avoid operating. So the treatment of this acute phase is steroids. And then when people enter the quiescent sort of obstructive phase, that's really when you can entertain surgical therapy. But I think most people would say that you should really only do upper extremity revascularization for either symptomatic carotid disease or critical ischemia of the upper extremities. This is, if you can, you do not want to be operating on Takayasu's for claudication and a little nuisance claudication of the upper extremity. You have to have a fairly high threshold to intervene on these folks. Giant cell arteritis, similar to Takayasu's, but it doesn't affect the aorta and large arteries. It affects mostly medium arteries. So a little farther out the arm, the axillary artery and the brachial artery. Again, it's more common in women than men. The initial treatment's corticosteroids, and you reconstruct only in the chronic phase for very severe ischemia. You'll see a handful of patients who, will have non-occlusive ischemia for different reasons. And it can be really sort of, I don't know, it's frustrating to see, in a surgical practice, you really, often are sort of left without knowing what's causing the problem. So you have to eliminate whatever the triggers are of this severe vasospastic or inflammatory response. And then the most common thing that, you know, is very good first-line therapy is to start a calcium channel blocker. So, you know, when I see this kind of patient, I'll typically start nifedipine and then try to transfer the patient over to either a vascular medicine specialist, sometimes a rheumatologist, who might be able to sort of fine-tune things from there, is the bottom line, how I think a lot of surgeons handle these in practice, to be, you know, titrating the doses of medications, you know, with all the other medications they're on. I think it gets a little tedious and a little difficult. But we certainly have to know how to identify these patients and start initial treatment. Hypothenar hammer syndrome. So this is, you know, this is obvious here, aneurysm of the ulnar artery as it comes around the hook of the hamate, you know, and the typical story here is obviously somebody who's a roofer or a bricklayer, a lot of trauma to the heel of the hand, and that's a important diagnosis to make. And the treatment, as was shown before, is resection and some sort of interposition grafting generally. You know, Dr. Matos mentioned this. You know, what's well described is to use the veins of the foot as a very good size match for this repair. Now, I still think that most people would go to the arm and get a piece of basilic or cephalic, but you know, the veins of the foot actually tend to make a good size match for this repair. So I think at that I'm gonna stop. So I'm a little bit over. Okay, thank you very much.